everyone. Today, in my capacity as one of the assistant editors for the Rhetoric of Health and Medicine Journal, I have the pleasure of talking with authors Liz Angeli and Christina Norwood about their piece that was published in the very first public health special issue of the journal. And their piece is a persuasion brief titled The Internal Rhetorical Work of a Public Health Crisis Response. So welcome, Liz and Christina.
Great. Thank you. Thanks for having us.
Yes, of course. Yeah. And I just wondered if you both could just introduce yourselves to the audience, if you don't mind.
Sure. As Catherine said, hi, I'm Liz Angeli. I'm an assistant professor at Marquette University, where I teach and study technical communication and the rhetoric of health and medicine.
Excellent.
And I am Christina Norwood. Graduated as an understudy of Liv at Towson University. Now I am a technical writer-editor at the National Cancer Institute, where I do a lot of work with patient content related to cancer and cancer treatment.
Excellent. Well, thank you both again for taking the time to do this interview. Your piece, your persuasion brief is great, and so I'm really interested to learn more about your process and for you to tease out some of these concepts these rich concepts that you worked out from your data. So the first question I have for you is, your persuasion brief shows how a rhetorical concept, specifically techne, allows you to name and parse and thus illuminate a set of complex communicative processes in public health that are underdescribed or under-theorized. Could you say a bit more about how the specific theories of techne you were drawing on in your analysis allow you to theorize what you call gut feeling?
Yeah, so looking at techne, I'm not going to lie, it was a little intimidating because there are so many different theories out there, and we really went back and forth of, is this techne or is this phronesis, and what's the dividing line between the two? And I'm going to kind of go out on a limb here and be a little bit vulnerable. It can be really intimidating writing about theory.
Yes.
When Christina and I really, this is one reason why we work so well together. We really live in that theory practice balance. And so, when we're like, okay, there's something going on here with, rhetorical concepts, what are we gonna take up? And techne seemed to be the best fit because it was capacious, yet it was structured enough to let us, talk about what we saw happening in our data with our transcripts and the written information that we were collecting from the Johns Hopkins Medicine Ebola Crisis Communications Team. Wow, it was such a long name. But so I think we might be referring to it as the ECCT when we go forward because it's a mouthful.
That sounds
so we were able to look at these the particular aspects of techne, focusing on the idea of habituated expertise and experience, because that's what we really saw the team referring to when they were trying to revise these protective or personal protective equipment guidelines. The two people we sat down with, they kept saying, we have a lot of expertise in the field. The people on our team had a lot of expertise in the field, and we used our experience, we used gut feelings, and they really focused a lot on limitations. And so, those are all aspects of techne, and we really relied mostly on Janice Lauer's work with techne and Janet Atwell's stuff too, just because it seemed to align. It aligned the most with this public health crisis communication that we really, that we were working with.
That's great.
And just to add to that, just talking about medicine or the practice of medicine sort of blend itself nicely to this sort of theory because it sort of also meets all of the different qualifications. So it seemed like techne was a natural fit to discuss, something like a crisis communication, especially in the healthcare medical sector.
I completely agree with that, Christina. And just for both of you, I think techne was absolutely the right choice, and I agree, Liz. And I think that's great that you said that, because for people who are maybe thinking about writing from a theoretical perspective, maybe they would feel more invited in to do it by having great models like yours, but also learning even these scholars and practitioners, writers who are incredibly smart, they too feel like it can be intimidating. But I think the fact that you're trying to describe and under-described, under-theorized, I think that it's too easy to say that particular team, they just did a good job, who knows why, and you're trying to extract some kind of technique so that other people could, and you did this beautiful heuristic. And so I think Techne was absolutely a great choice. And I think that you articulated that well.
I think to add on to that too, this is another reason I love working with Christina, and just we'll provide some background later, but like Christina mentioned, when I was at Towson University from 2012 to 2016, she was in our Master's of Professional Writing program, and that's how we started working together. And, it was so nice just going through this. It was, knowing that we were writing a persuasion brief that is intended to be written by practitioners, you want to use theory that can be easily explained and easily understood by people who are doing this every single day. And really, I mean, this is not an overstatement, trying to save people's lives. I mean, when it came to the Ebola crisis, I don't know if we all remember how scary that was, and the level of lethality of Ebola is pretty intense. And so it was it was just important to us to make sure that we weren't trying to grapple with something that we could not explain in a persuasion brief.
Absolutely, and I think that is really important. That's the purpose of this genre. And if you're doing it well, you want it to be something you can hand to practitioners, and they will not feel like it's esoteric over academic nonsense, right? And so, but that's what is so beautiful about what you did, the way that you used it in your piece, is that you are using a dense, complex rhetorical concept, and yet making it like a totally logical thing in the way that it's used, and also offering very clear takeaway from its use. So I think was really great.
Cool. Yeah, thanks.
So the next question I have for you two is, I really appreciated your emphasis, especially on the complexity of the rhetorical situation and the communicative tasks at hand during the early days of the Ebola crisis. You really recreate that well in the text. You successfully emphasize the need for timely, effective communications with multiple stakeholders and with a variety of purposes. What is striking about this case is that it resists oversimplified approaches to invention. So I love the idea of offering this heuristic that I mentioned already, that you developed, that takes stock of how and why the case you examined was successful, such that future health communicators might benefit. How might this piece also be useful in classrooms, do you think?
Well, I mean, I think what's special about this case is that we initially, as Liz mentioned, it sort of started in the classroom as a real world example, something that was unfolding in real time. And at the time, in 2014, there were some unknowns, and so it was just a very interesting way to sort of discuss failure in the classroom and sort of theories around that. And so it's very helpful. I think that just having a case study where you can sort of follow it in modern times from start to finish is very helpful and relevant for someone who is learning to do this and then will, have a role potentially in, a similar topic as a professional. Okay. So, I just thought it was tremendous value in it. It was an awesome learning experience. Like Liz mentioned earlier as well, we were both able to blend our experience, as rhetoricians, and then having also some healthcare background. And so that's really what sparked the discussion. We were looking at these things, and I had experience, for example, with the PPE, dolphin and donning. As an undergrad, I spent time working in the hospital as a IV pharmacy technician. I prepared chemotherapy, things like that. So I routinely had to put these things on, and so just having that perspective on it, it got a wheel spinning a little bit about, is this right? Does this make sense? What? And then we started looking into, what was their rationale for choosing this PPE versus another one?
Interesting.
So, yeah. So, I mean, whenever there's something that's real world happening, I think it's the right time to, try to capture that in the classroom.
Right, that's great. So it's almost like Kairos driven. It's this thing is actually happening. There's this really well-rounded case study. It has some links to what students know about and do outside the classroom. That's brilliant. That's really good.
And to kind of go back to the oversimplification, the one thing, and the beauty of Towson's, I'm going to do a kind of a plug. The beauty of Towson's master's program is that most of the students, I mean, I don't think it's changed that much because I haven't been there in a few years, but they're just like Christina. They are working during the day, usually for some type of government agency, and then they come to class at night. And when I would bring in, the PPE, it's super easy to be critical and Monday morning quarterback of, I can't believe the CDC would have done this and blah blah blah. And we pushed back against that and drawing on all of the, like Christina said, the knowledge that we had in the classroom. Christina's knowledge in healthcare, my knowledge of being a healthcare provider. We thought, okay, there's something going on here. It's not that easy.
Right.
And because when Christina and I were preparing for this interview, we remember like, oh yeah, I think I had heard on the local NPR station or something that Hopkins was involved in the revision of the CDC's PPE, and I brought it to class that night. And speaking to Kairos, and I remember, we're in the same city as Hopkins. I had a former student who now works at Hopkins. So why don't we do something about it? And Christina was super, I can still remember the energy in the room that night when we talked about this. And, this is going on 5 years ago now.
Right.
Of this sort of, let's look into this. Let's not just sit in the classroom and talk about and criticize. Let's get to the bottom, investigate what's going on behind the scenes, because it's never as easy as it looks.
Absolutely. I think you're complete. I mean, I think that is a real challenge, and that's what I like about RHM being at the intersection of the sort of the hard sciences, the social sciences, the humanities, because certainly from some like real high up in the humanities spaces, ideologically, it seems like all you really do, if you're looking at something from the outside, is say, well, this is everything they did wrong. And not really having any empathy for working professionals and the fact that this is their day-to-day life and this is them doing their best and they're not like setting out to do harm or anything. And so I think that that is definitely the viewpoint that you all sort of espouse in your piece, and that's made it really good. So.
I was just going to say, to that point, and you probably might have been about to say something similar, is that there's also something to be learned from failure. And the CDC and the, rest of the infectious disease community, as well as everyone who was, involved in any sort of tangential way, also learned a lot from this experience. That's also the interesting thing about this is that we're sort of documenting a failure and then correct, and part of that, what was happening in the classroom is that sort of gut feeling thing. Like there seems like there's more to this. From my experience, I think my reaction was from my experience in preparing, IV, I wouldn't feel comfortable. Like I know like all the areas that are exposed, I wouldn't feel comfortable with that. So it was like, why did they choose that? And we'll probably get into why they chose that later, in our discussion. But it's just a fascinating topic to me.
Yeah, I love how you said that. I mean, that's great, Christina. Absolutely, all the things that can be learned from failure and the course correction that followed. That's great. So.
The only part I was going to add on to that, and just Christina bringing up the gut feeling part. This isn't something that we really wrote about, but just the classroom experience of faculty, master's grad student co-authoring, because I think so often we and this might be an oversimplification, but it's usually the doctoral students co-authoring with faculty, and Towson's master's programs, it's a terminal program. There is no Ph.D. at Towson, and so it was such a great experience. And I might just be speaking for myself. I don't want to put words in your mouth, Christina. But it's been so fun. I mean, I've learned so much from Christina. She'll push back and go, you know what? When we're analyzing that data, I'm not seeing this the same way as yours. Like, okay, you're the one who's going to the NIH every day. Let's figure out what's going on. Drawing on your expertise as a tech writer. Just to, I don't know, just get those different perspectives. And I think what Christina was saying, that we sort of were enacting what the the Ebola crisis communications team was doing too.
That's
Trusting each other,
cool.
letting each other take the lead in certain cases. When we presented at 2 or 3 conferences.
Wow.
At least.
I can't remember. I think, yeah, it's been at least 2 or 3. We've got 2 publications out of it now. And now that, we're in 2 different cities, this still connects us,
Yeah.
I mean, it just,
No, it's really great. I mean, it's great. And I do think that it's so different than if you were to collaborate with a doctoral student who's also going the academic route versus someone who has a clear practitioner role and lots of expertise that academics don't. And so I bet Christina was the ideal collaborator, and like you said, a chance to extend that relationship beyond the classroom. So really great.
Yeah, I mean, I don't want to linger too much on this question, but I have to say that I agree with Liz about the experience. It was very unique. I came in, as a tech writer already entering the master's program fairly far into my career, but I had been to being behind the scenes. So to do things like speak at conferences and, sit on panels was very new and kind of scary to me. And it was nice having Liz as that support, to sort of give me the confidence to do that. And so once you do that, then you're like, oh, well, I can do this. And,
cool.
And that sort of inspires you and gives you confidence to do other things. So I think that just having this experience and being willing to sort of go out of the comfort zone, knowing, this is something that you're terrified of, but you're going to do it anyway. That in and of itself was just something that something that I didn't anticipate coming out of it. And so that's also wonderful. Just as tech writers, our voice is usually on the paper. And so I just really appreciate that part of it. And her trusting me to, partner with her and do all the things. I learned so much, and I think that, at this point, I feel like I'm more senior level in my career, but, I just think it's important to always have a mentor and to be a mentor. I mean, you can do those things at the same time.
Right.
And, I always try to do that as a professional. And you just learn so much. You learn so much from teaching, and you learn, so much from someone who's willing to share. So, there's so much, like, outside of the things that we produce, there are so many other things that came from this that I'm really grateful for.
Yeah.
That is great. I'm glad, actually, that you added this to the conversation, because some people might be thinking, okay, if Christina is not going the academic route, then beyond maybe the feather in your cap of publication, what are you getting? And you articulated that really, really nicely, that actually these experiences have built your confidence, and that's going to manifest itself in a whole variety of ways as you continue to build your already pretty established career. So that's really great. So the next question I have for you is, your candor, I thought, on the process of data collection was very refreshing. You note that your calls and emails went unanswered. I feel like these are the kind of research stories we don't hear enough. So when you were attempting to include leading patient safety experts in your study, they just weren't getting back to you. So I just wondered, since you were brave to share this, and I thought refreshingly so, what advice do you have for other researchers who are hitting roadblocks in data collection? And I'm thinking in particular of early stage researchers that are like, well, they didn't get back to me, so the project's over, right? Like, you come across this. So I thought maybe it would be great for people to hear more from the two of you about how you kind of stayed the course, right? Beyond these roadblocks.
This happens all the time.
Yeah.
I mean, it does. It's not even just, I think, in academic research, but I mean, sometimes people aren't going to get back to you for whatever reason.
Right.
And it's easy to take it personally. But it's not personal, I mean, or I'm sure most of the time it isn't. I mean, the person who we were trying to contact is a very prominent figure. And, and the people in RHM and people who work in the medical field know that physicians are very busy people and wear a lot of hats. And, we were grateful that Dr. Marigakis even got back to us I was like, oh, okay, great. This is good. And Mr. Buchanan, Ben got back to us too. But we tried, I think, 3 times. That's usually what I do. Is if I'm not hearing back after about 3 attempts and waiting about 5 to 7 business days, and Christina was obviously in on the decision making with this too, because it wasn't just I wasn't just going to make the decision myself to just let it go. It's like, okay, this door might be closing for a reason. Let's not try to pry it open. Let's see what else we can do. And the beautiful thing about this particular project is that there was a ton written out there about what Hopkins was doing with CDC and PPE. And so, we combed the internet and just were looking for press releases and news releases and searching and combing through social media. And Ben Buchanan helped us with that too, trying to figure out, where to go and how to tell the chronology of everything, which was pretty difficult. I mean, that was the one thing. Christina, she pays such attention to detail. Sometimes we'd be writing drafts and she'd say, this happened before this happened.
Oh, wow.
And I'm like, all right, change it, because because we just had so much information we were getting. And, there came a point where I think a lot of times you never think you're going to have enough data. And 2 interviews can get you enough data. And if you've got, a bunch of textual stuff to, talk about, I mean, yeah, we have gotten, I was just remembering, we have gotten 3 conference presentations out of this and the two publications. And they're different enough to be 2 different things.
Wow.
So it was, I don't know, but it's, I would encourage people to be vulnerable and write about these roadblocks.
Yeah.
I obviously, as you can tell, Christina and I are pretty candid.
Yeah, no, I mean, in a good way, in a way that's going to help other people. And I know Lisa and Blake are working on these ethical exposures essays that were due, I think, at the end of August. So hopefully there will be, I know that one of their agendas is to have more content in the journal that speaks explicitly to problems and issues and methodologies as well as like tactics for overcoming. But I did notice, I thought, wow, this is great. Because I think a lot of times when in the write-up, people want to like tell the story about just the blow by blow. Oh, these were my methods, and maybe in a footnote you might see here's something that didn't go well. But I loved that right in the body of the essay it says these calls and emails went unanswered, and on we went. And so this is I think great advice for other researchers that there is other data out there, and there are a lot of riches in even 2 interviews. So I think that's great.
Yeah, it seemed appropriate for the topic too. Like, it just seemed, in the context of what we were writing about and the limited information that was available, it just seemed appropriate to, openly acknowledge, that we encountered that. And I also just wanted to mention, like, the people that we were able to interview were very, very qualified. So Dr. Maragakis, for example, she was the Senior Director for Healthcare Epidemiology and Infection for the Hopkins system.
Wow. And
she likened that to the public health arm of Hopkins. So, she was very, it was very nice to have her here. And she was very open to information and giving background and context and things like that. And she had a direct role, in this process. So, we didn't get everyone that we wanted, but I think we had certainly enough to go on that we felt like we had something that was worthwhile to share. And the same Ben Buchanan, I think he was like the communication lead in marketing, so he also had his role in this process. So we definitely, I think, still consider like the cup half full with who we're able to get.
I think that's really important to point out that these were pretty heavy hitters that you were able to speak with. So it's not like you took like Team B or something like that. So,
and just to add, and I realized I pronounced Dr. Maragakis' like name wrong. I remembered the Mary part. Okay. But what she, because as Christina said, she is so prominent, she had publications out about this by the time we were getting ready to write, because medicine and science just goes. And so she had publicly available slide decks that we were pulling from. Wow. And so I think that's another piece of advice that I share with people is if you're interviewing these big heavy hitters like Dr. Maragakis, you look them up in databases, Google Scholar them. You'll find stuff.
Mm-hmm.
And kind of, speaking of Lisa and Blake, because I know they've got, and this is going to be a shameless plug. I wasn't sure if I was going to do this, but I'm doing it.
Do it.
So, in Lisa and Blake's methodologies for the rhetoric of health and medicine, my chapter in there is all about overcoming roadblocks in research projects. And I drew on a lot of that, trying to figure out, okay, so if this interview is not going to come through, what are the other venues and avenues that we can get to kind of triangulate some of this stuff? Or if an email isn't working, maybe we should try a phone call, or maybe there's a different admin assistant who we can contact. Or maybe, Mr. Buchanan at Ben could try to get us in with someone. So.
Okay, that's great. So for people who are looking for real, tangible strategies, that chapter is a good resource also.
I think so.
Yeah, no, I'm sure it is. I have to read it. So I'm making my way through that collection. It's like a little dessert to other readings, when you're doing lots of other, I'm going to read one of these chapters. So it'll be next on my list. Okay, so the next question I have for the two of you is, an intriguing part of your heuristic and your analysis leads up to it is the emphasis on, quote, considering failure points and limitations as an important step to, quote, finding avenues around them. What other applications might such an approach have in related health and medical situations? Giant question. So even if you just take a little slice of it, that's...
Sure. So I guess where it has pretty much in all of health and medicine for the most part. And it doesn't necessarily even have to be a crisis per se. But if we, stay on the area of crisis, I'm thinking, a natural disaster, some sort of, anything, bioterrorism, out of the health sector a little bit, potentially like a marketing crisis. Those happen quite frequently. Some sort of, financial crisis. So there are so many applications where, the steps they took to sort of mitigate would still be relevant. And if there's something for technical communicators to learn from. So, I guess if we're thinking about, where it can apply, I use, some of the heuristics that we worked on and refined in this paper and work, and, it's not necessarily that I'm always writing about a crisis, but I do write and edit content about cancer and cancer treatment. And then there are, difficult things to talk about, like prognosis, when treatment isn't available and, those kind of things. So whenever you're writing with the intent for someone to act on what you're writing upon, I think that this has relevance.
That's great, Christina. You're pointing out that this has lots of applications, even in your position, and that it doesn't always need to be something that's a crisis situation for that focus on failure points and limitations and with avenues for around that. That's great. That's really
something, because when Christina and I were preparing for this, we talked about how a lot of the sciences in health and medicine is all about data. Mm-hmm. And as we know, data is more than numbers. Your body gives you data when you're in meetings. And, if you're going like this about something that's going on, it's just, okay, what's your body telling you? Mm-hmm. Are you anxious about something? Are you feeling insecure and threatened? Why might you be feeling like that? Is there a failure that you're coming up against and there's fear that's underneath that? And just, having the kind of the confidence to break those open a little bit. And it's one of the things that we were hoping with the heuristics that, if people use it, okay, this isn't a published, peer-reviewed journal article, so it's got some, ethos behind it, right. Just to kind of pull that out. And, and a lot of the stuff that we're talking about, as I was just thinking about the heuristics, and everything's really grounded in, slowing down, not reacting. Sometimes you have to, but, that was really what the ECCT did at Hopkins was they weren't quick reaction. It was, okay, let's take our time a little bit. They didn't have a lot of time, but, sometimes just pausing for 30 seconds just to do a check-in about, okay, so-and-so's got expertise in this field. Maybe I don't have as much expertise in that field, so now it's my turn to just listen and let someone else step up. And if I have issues with that, I got to deal with it, I mean, so it's just, I don't know. I do think there's a lot of value in just the whole concept of not throwing down, slowing down.
Slowing down. Yeah.
Not
Yeah.
throwing down. That's a whole different thing. But just yeah, and I that's another reason why co-authoring with Christina is so great, is because we were teasing these heuristics out. She would say, I feel like I could do this in a meeting, or I actually did this yesterday. Here's another question we might want to add.
That is
And
brilliant.
so that was, I mean, even in faculty positions, I think we definitely can use these heuristics too, because they apply to much more than just the practice of medicine and healthcare.
Well said. Absolutely. So, yes, very important. And
it was very interesting to hear Dr. Maragakis go through this whole part, about the considering failures and limitations. I mean, this was sort of the impetus to why Hopkins sort of stepped out on a limb and did something different from what CDC was recommending. That was pretty controversial at the time.
Okay.
And it was that whole thing of, you have to do what you're asking your readers or your audience to do. And so she and her team of nurses, physicians, all these, ER personnel, they went through the process of doing what the CDC said, and they came to the conclusion that this doesn't feel right. This is, I don't feel safe. I don't feel comfortable asking my colleagues who are my friends, to do this. So they decided that, that failure is too great in this context. If the CCD didn't work, it was potentially fatal. And so that was the way that she walked, and we did go through in our paper and sort of recap her thought process behind that and how they arrived at something that was sort of, in a lot of ways, counter to the recommendations at the time. And so it's very interesting when you do that. I think when you do the acts that you're requesting others to do, then you do come to other conclusions, and you can sort of find those gaps and limitations. And I think that's the benefit of having transdisciplinary teams. You can get that at least, interdisciplinary, and the different things. Transdisciplinary is the diverse groups with different backgrounds working throughout a process. Inter is where they sort of intersect at different points, but I think it's very important to get the different perspectives in very early. The people who are asking to do this thing, as well as sort of the thought leaders, are the ones who are giving the guidelines, if you will. And that was also a huge strength of why they were able to do what they were able to do, because they did bring in a lot of people from a lot of different backgrounds. They brought in writers, human factors, they had health professionals, they had the CDC, and they all, worked together to modify this. And this was a very time-sensitive thing. And, something that they probably would have taken many, many months to do. They cranked out this revision, these videos and training, things like that. I think Dr. Maragakis said in 2 weeks.
Wow.
Which is, mind-blowing. When you think about it, that was definitely some urgency. And, I guess that also goes back, not to go too long, but it also goes back to the whole thing about, not always having all the data. Sometimes you flesh it out as you go.
Yeah.
And that's the only choice that you have. We never really have the luxury of having all the answers. And there's also that thing called, paralysis by analysis. And they didn't have that, they didn't have that luxury for this. They relied very heavily on gut feeling. So for this team, the data were just one component of their decision making, and I think that's very important, especially in this medical, it's uncommon sometimes.
Absolutely, I love that the strength of the interdisciplinary perspectives coming together, the working with what they had in this very time sensitive sort of way, and that in those contexts, relying on something like gut feeling becomes really, really important and effective. That's great. The last question I have for the two of you is, if you could just take it individually, what's next for you? What are you up to? What's on the horizon that you're excited about that you want listeners to also know about?
You want to know what my first word is after that question in our notes?
What's that?
Awesomeness.
Awesomeness. Okay.
We are, what you can expect to see is awesomeness, but probably not what you're expecting. I don't know, Christina, do you want to go first?
Oh, well, sure. So, I sort of alluded a little bit, for the last 5 or 6 years, we have sort of almost feel like it looking back, meteoric. There's been a lot happening very quickly. I've had a lot of great things happen in my career. And I've, done a lot of things while working full time. I have 2 children, I'm married. And so for me, and I was talking to Liz about this, I think for me, like, what I'm looking forward to is just like patting myself on the back a little bit.
Yeah. Great.
And just being appreciative of where I am and, kind of soaking that in. And, maybe sometime later, there'll be another project, or something like that. But I feel like right now I'm in a very good place professionally, and it's because of all the work that happened before this. And so I just want to take some time to appreciate that.
I love that. The pat yourself on the back. Just rest on your laurels just for a minute. I love that. That's great.
Yeah, we've been doing this, like you said, since 2014. That's 5 years now. And so, and there does come a point, I think, with projects like this where how much longer can you write about it, and before it's sort of, okay, we're getting on 10 years now, 15 years. It's not just that there's not value, but if we really wanted to push it, or not push it, but extend it, we'd need to start doing more case studies. And we're in different time zones now. We're in different parts of the country, and that was great when Christina and I first started talking about this. That was one of the first things she said. She's like, "Let's talk about that last question." And I said, "Okay." I said, and when she said, I'm cool with where we're at, I said, "You know what? Yes." And I don't think that's something that is shared enough.
Right.
Just being satisfied with the work that you've done, and just knowing that some research projects have sort of this lifespan. But sort of on my end, in terms of the research that I'm doing, I have, I guess, 3 big things. I have 2. I think most people know that I work with emergency medical services, and I'm starting to expand to EMS services that also are fire services. And so I'm learning a lot about fire report writing. And I have 2 pretty big research projects going on with 2 different agencies right now with that. And so it's my happy place. I always say any day I get to spend in a firehouse is an excellent day for me.
That is so cool. Have you met Tim Amadon?
Oh yeah.
So you know Tim. So
yes,
yeah, that's kind of his. So that's amazing. I love your work. I mean, I always say, and since I saw you present at CEAS the first time, it remains the best conference presentation. Like just in terms of polish and takeaway, like you go to some that are great, and you go to some that are serviceable, and that one I was like, that's the best one.
Thank you.
Yeah, so I'm a fan.
That means a lot. Wow.
Yeah, so I'm a big fan. It was just very polished. I mean, everything was crystal clear. It makes a lot of sense from reading some of your other work and talking with you, just as a thinker, that it was not overly academic. It was very practical, but not less rigorous or interesting for that. Makes sense. But yeah, I think that you have a way of making the complexity really palatable and something that lots of different people could benefit from. So that's great. Including in this persuasion brief, the 2 of you did a really nice job. So super excited to be doing this, to have done this interview with the 2 of you, to hopefully to keep pushing out and making people aware of it, and even having it be a really great companion piece for people that want to assign it in their classes, to then be able to hear Christina telling the story, the backstory, to hear the explanations of some of these moves that you made in your collaboration.